Hi, everyone. I'm Dr. Clarke. I'm a surgical oncologist at the Medical College of Wisconsin. And today we're going to talk a little bit about understanding liver surgery for neuroendocrine tumors. I have no disclosures, and neuroendocrine tumors are one of my favorite topics, so hopefully we'll have a robust discussion after these presentations. So as you've already heard, neuroendocrine tumors are not as rare as we initially thought they were. The incidence of neuroendocrine tumors is actually on the rise. And because of the relatively indolent nature of these tumors, there are hundreds of thousands of people living with this disease in the United States. Unfortunately, because they're not commonly encountered, neuroendocrine tumors are not often at the top of mind for physicians when patients present with symptoms. And so patients tend to present with advanced disease at the time of their diagnosis. For this reason, really seeking care from experts that understand neuroendocrine tumors and understand how they behave is really important to guarantee your best outcomes. One of the first questions I always get when I meet patients with metastatic disease is, how will my neuroendocrine tumor behave? It's often very scary when somebody's told that they have stage 4 cancer. And so this is when I really have to have a nuanced discussion about how liver metastases may actually affect your overall survival. So the first thing to understand is tumor grade. And this really plays a critical role when discussing outcomes for patients with liver metastases from neuroendocrine tumors. Grade 1 tumors are low-grade tumors that are well differentiated, and these cells divide at a slower rate. These tumors can really be more indolent or slow growing. And for that reason, people can live decades, even with stage 4 disease. Intermediate grade tumors divide at a slightly higher rate than low-grade tumors. And then high-grade tumors are faster dividing and are more aggressive and grow more quickly. Tumor differentiation is also really important. If your tumor is well differentiated, it's a neuroendocrine tumor. If it's poorly differentiated, it's a neuroendocrine carcinoma. And this distinction is really important because in general, surgery, especially in stage 4 disease, is primarily only considered for neuroendocrine tumors. And very rarely, only in special circumstances where patients really respond well to therapy, do we employ surgery for neuroendocrine carcinomas once it's spread outside of the primary lesion. Now, we see a lot of patients with neuroendocrine liver metastases, and that's because a lot of patients with neuroendocrine tumors will develop distant metastasis, and the liver is the most common site of metastasis for all comers. About 80% of the times, the liver will have disease. And so surgery is often considered for two reasons. One is to improve symptoms for patients that have functional tumors or tumors that are excreting hormones that are causing a symptom. And then also to provide a survival benefit whenever possible. But not all NETs are created equal. And there are a couple of factors that we really need to take into account when we talk to patients about how their liver surgery will help them and how much of an impact it will have on the overall survival. Really, if liver surgery is going to benefit you, there are three things in particular that will affect your outcomes. One is the primary tumor location and whether or not you've had previous surgery. And we'll talk a little bit more about that later. As mentioned, we talked about tumor grade and differentiation. That really has an impact on your overall survival. The volume of disease in the liver, again, we'll talk about that more. But most importantly, this decision should not be made in isolation. If liver surgery is going to be beneficial to a patient, that really needs to be discussed in a multidisciplinary setting, and the consensus recommendation from all involved needs to be, I think, the most important thing. So primary tumor location, why does it matter? And why does previous surgery matter? Well, there are a couple of special considerations primarily to be made for pancreatic neuroendocrine tumors and duodenal neuroendocrine tumors as well. So many of you may have already had surgery and are probably very familiar with a Whipple procedure. A Whipple procedure is performed for tumors in the head of the pancreas or in the duodenum, and it involves removing the head of the pancreas, the duodenum, the common bile duct, and a portion of the stomach, and then reconstructing the GI tract to ensure that you can eat and drink normally. The challenge with this operation is that in order to restore continuity, one of the connections that we make is between the remnant common bile duct and the duodenum. And what this does is, because there's bacteria in our intestines, when we have a normal anatomy, there's a valve that protects the bacteria from flowing into the common bile duct and into the liver. But after a Whipple, because we've had to remove that valve, we now have free flow of bacteria into the liver, which doesn't normally occur. That's not a problem if your liver is intact. However, it does complicate liver surgery after. And so after Whipple, the ability to treat lesions in the liver actually is significantly compromised. Because of this bacterial introduction, if you have liver surgery after Whipple, it really increases your risk of infection, abscess, and sepsis. It can be quite lethal. And then some other treatment modalities like liver ablation, sometimes TACE, which is a chemoembolization, those things can also cause significant infections. And so for patients who either need a Whipple procedure or have had a Whipple procedure, the conversation about when to do liver surgery and whether it's the right time is actually quite nuanced. So it's very important that your surgeon understands that distinction. This is not the case for distal pancreatic neuroendocrine tumors, and it's not the case for neuroendocrine tumors from the lung or the small intestine. This is a particular problem for lesions in the head of the pancreas, and only because of that special connection that we have to make after that surgery. Another consideration for primary tumors is that each primary tumor actually behaves differently. So this is data from a study looking at patients that have synchronous liver metastasis, which means they have liver metastases at the time of diagnosis of their gastroenteropancreatic neuroendocrine tumors. And what we see is that for all comers, there are differences in overall survival based on the primary tumor. So in general, neuroendocrine tumors of the intestine, small bowel, do better than neuroendocrine tumors of the pancreas, which are on the graph in green, and neuroendocrine tumors of the stomach. That's because most of the neuroendocrine tumors of the intestine are either grade 1 or grade 2. Pancreatic neuroendocrine tumors can be anywhere from grade 1 to grade 3. And then most of the stomach neuroendocrine tumors are actually higher grade, grade 2 or grade 3. And so what we're seeing in tumor biology is really a reflection of the tumor grade. We sort of see a little bit of a similar pattern in patients that undergo surgery. In general, we do get pancreatic patients and small bowel neuroendocrine patients almost having similar outcomes after surgery, even in the setting of liver metastasis. But for gastric patients, there's still a slightly lower overall survival. And again, that's because those tumors tend to be more aggressive or fast growing. This diagram basically also explains the same thing. When we look by tumor grade, with grade 1 being the most beneficial after surgical resection, most patients will survive for a longer period of time overall with grade 1 disease and also have a longer disease-free interval, which means that a longer time before tumors recur when compared to grades 2, which is in the middle of the curve, and grades 3, which is at the bottom of the curve. And so your tumor grade really is important to your outcomes. Again, tumor grade is just a measure of disease aggressiveness. For grade 3 disease, because we know that the prognosis is not the best with surgery alone, we often will not employ surgery first in these cases. Even in the setting of localized disease, we'll often try to treat with some systemic treatment first. But certainly in the setting of liver metastases, we recommend systemic treatment first, controlling the disease, downsizing as much as possible, and following up with surgery in patients that respond well to therapy. For low-grade disease with liver metastasis, surgery provides significant benefit. And in intermediate grade, this is a little bit of a gray zone, and you'll see some institutional variation here. At the Medical College of Wisconsin, we usually try to induce a little bit of systemic control for a couple of months prior to surgery to make us feel a little bit more confident that we're going to be able to remove as much visible disease as possible. And then, of course, tumor volume. As you can imagine, the image on the left shows a single liver metastasis. This is a much easier problem to fix than the image on the right, where we see multiple lesions all throughout the liver and involving both lobes. This is because for patients to do well, we have to really have two main objectives. One is to remove as much visible disease as possible. and more importantly, to leave as much healthy liver tissue behind. Just remember that surgery is just one tool in a whole armamentarium of treatment options for neuroendocrine tumors. And because many of our patients will survive for decades, we need to make sure that the surgery doesn't compromise your overall survival because we're doing too much. The average person needs about 20 to 30% of healthy liver tissue to basically sustain the body. And so surgery for neuroendocrine tumors really needs to take that into account. So, for example, we see a liver here that has a single tumor, and in many disease sites, sometimes in colorectal cancer, sometimes in other kinds of cancers, we'll do a formal liver resection, which means we'll take half of the liver and remove that tumor. But in neuroendocrine tumors, we can't do that, right? Because many patients, even though they only have one visible tumor, they may have microscopic disease in the remnant liver, and that disease will eventually grow. But more importantly, again, because patients can live such a long time, we need to leave as much healthy tissue as possible. So it's very rare that we do formal resections. Instead, what we tend to do is what we call cytoreduction or enucleation of the tumors, where we just shell the tumor out of the liver and leave as much healthy, normal liver behind. The goal here is to remove as much visible disease as possible, and it's really not necessarily aiming for a cure, but certainly we know that outcomes are better if we decrease the volume of disease that's left behind. So this is another graph looking at patients that are able to make it to surgery with liver metastasis and patients that don't. So for all cases, surgical patients do much better than patients that don't make it to surgery. And the trend is the same for all neuroendocrine tumors, regardless of location. So right at the top is our small bowel or intestinal neuroendocrine tumors. Left bottom is pancreatic neuroendocrine tumors. And right bottom is gastric neuroendocrine tumors. And you can see a big separation in the survival curves for patients that are able to make it to surgery. So we think that surgery is very important for patients with stage 4 liver metastases in conjunction with other treatment options and treatment modalities. Surgery plus other treatments really provide the best outcomes for our patients with neuroendocrine liver metastases. So how much of the liver disease do we need to remove? And there's actually a fair amount of data that discusses this. Somewhere between 70 to 90% has been demonstrated to actually positively impact overall survival. And so that plus removal of the primary tumor whenever possible really gives our stage 4 neuroendocrine tumor patients the best chance for a long survival. And sometimes also can help give us little treatment breaks from systemic treatments as those side effects and toxicities can add up over time. One thing for your surgeon to understand and discuss with you if you have liver or neuroendocrine metastases is that some patients are at risk for developing carcinoid crisis during surgery. These patients typically have symptoms of carcinoid syndrome before the operation, but your surgeon and your anesthesiology team must be aware of this and must have plans to mitigate this risk with medications such as intravenous octreotide, but also just regular pressors. And I know that this is going to be discussed in more detail by Dr. Halle, so I'm not going to spend too much time on this, but certainly this needs to be a part of the discussion for every patient undergoing liver net surgery. And then always remember that even when removing all of the neuroendocrine tumors is not safe or possible, there's some treatments that may downsize the volume of disease and convert some patients from unresectable to resectable. So again, patients should be seen in conjunction with medical oncologists, radiation oncologists, interventional radiologists, and surgery to decide which of these modalities is the most effective one for your disease and whether or not surgery can be employed either early or later on in your treatment course. These are some of the things that we may add to surgery to try to help either downsize disease or control disease after surgery, and your medical oncologist as well as your other physicians will discuss all of these options with you to see which one is the best option for you. So finally, even in the setting of liver metastasis, surgery plays a really important role in survival for patients with neuroendocrine tumors. I do always highlight with my patients that oftentimes we are not able to get to a cure with surgery, even if it looks like we've removed all the visible disease. What we're trying to do is to systematically convert this into a chronic disease so that you can live very long with good quality of life, and hopefully the time between needed interventions is really, really long. And that increases with lower grade disease and lower burden of disease in the liver. Most importantly, teamwork always makes the dream work, and a surgeon cannot treat you in isolation. So make sure you have a team that you're very comfortable with and that all members of the team are constantly talking with each other. But your surgeon is a critical member of your treatment team, and it's a lifelong relationship because hopefully you'll be surviving decades with your disease, even if we're not able to get you to a cure. So thank you very much. I'm going to look forward to more discussion later on.